You tell me how much I have and I double it, as usual. Good. So actually, the first presentation was part of management, because management starts really with making the right diagnosis. And so it's a continuum. So now we can say we're arrived at management, and once you have the diagnosis and you know you want to treat this patient in front of you, the question comes, okay, what do you want to achieve? What do we want to achieve? And what is the target? And of course, there's multiple targets that you could think of, and I'm not going into detail, but in principle there's 3 types of ways to assess whether a patient gets better. One is left, you look at change of composite measures. So like a thermometer. Something gets better on a continuous scale. Second one we know from the clinical trials, response criteria. Dichotomous yes-no tools that tell you whether someone has improved or not. And the third one is state criteria. You don't look at whether patients improved or had a response, but you just care about whether they are good. And the question is, what among these 3 is the right target? And the answer is relatively clear from the tree to target, and from the logic behind it is that we should go for state outcomes, for state targets. It's good to be better, but it's better to be good. That's the line that is important here. So remission is the target, and remission allows, if you look at, compare it to low disease activity, the blue one is remission. If you look at HAQ scores, you have better function in daily life than if you're just in low disease activity. So remission as a target is good, and I'm going over this quickly because I only have 15 minutes, but remission also improves cardiovascular risk factors, and even if you look at the last row here, the score, the cardiovascular risk score, if you look at patients who are in RA in remission, you can see they are lower than active RA patients. So remission makes a difference for many comorbidities and so forth. So the question is remission really always necessary? And I just want to spend a few minutes on that, because it's a very important question in clinical practice. If you have a patient who has improved but is not on target, do you continue to increase therapy, switch therapy, add biologics, whatever? Or can there be scenarios where you are maybe happy with just low disease activity? When you look at the treat to target recommendations, they say, well, if you have the long-standing disease patient, they might not be able to get into full remission because of joint damage, and it creates pain and so forth. So it proposes that low disease activity may be an alternative target. But there's another scenario also. It's when patients are treated with biologics. If you see patients treated with methotrexate, the progression, depending on which state they reach, is clearly different. When you look at patients who are treated with biologics, old infliximab data here, you can see patients in remission do not progress, but patients in clinical low disease activity also do not progress. This was labeled as the dissociation between inflammation and structural progression, but it tells us that if you're on a biologic treatment like a TNF inhibitor, for example, and your patient has improved to low disease activity, you may not need to change therapy just in order to get the patient further down to remission, because you have a good chance to preserve structural integrity. And this has, by the way, been shown for other TNF inhibitors, for IL-6 inhibition, for rituximab, and also for JAK inhibitors. And the third scenario where you may accept low disease activity is this here. If you look at the ACR-EULAR remission criteria, and the traditional definition was tender swollen joint counts less or equal 1, C-reactive protein and patient global the same, and you ask the question, you need all four fulfilled for being in remission. And you ask the question, if I have a patient where only 3 are fulfilled and the 4th is not fulfilled, what is the one that is mostly limiting these patients in near remission of being in remission. And you can see 61% of these near remitters, 3 or 4 criteria patients, have everything fulfilled except the patient global. And only 20% have everything below 1 except the swollen joint count and so forth. But the patient global is an issue for reaching remission. Inflammation is good, but patient global is above 1. And you can see here in a study that Paul Studenitz did that if you look at pain scores, you clearly see that pain scores increase the probability dramatically of failing to reach remission because of the patient global. Because patients translate pain to patient global, even if it's not inflammatory in many cases. So if you have a pain score of 25 or 30, you have an 80% chance that this patient, although everything else is remittive, cannot be classified as remission because of the patient global. So that's an issue, and that's a scenario that we need to understand, isolated pain, and that's a scenario where we may decide not to further increase biologic or disease-modifying therapy to get towards remission. Of course, we may decide to treat the pain, and we should decide to treat the pain, but it's again, the type of intervention, the patient is definitely not on target, but the type of intervention will be modified when you look at the case. And it is relevant. This is the frequency of comorbidities in rheumatoid arthritis. And there's one that is very among the most frequent ones, and it's depression. And depression is quite frequent in rheumatoid arthritis, and depression is linked to pain. Pain that is non-inflammatory. So it is a very relevant topic in rheumatoid arthritis to think about these non-inflammatory pain situations. So what happened recently was that the ACR EULA have adapted in 2022 the system, the classification system for remission by changing the cutoff of the patient global to 2. Just to make it consistent, which is now achieved, more consistent with the SDI definition. So the new remission criteria are not requiring the patient global to be less or equal 1, but less or equal 2. It's a cosmetic problem now because it's not 1 for all the markers, but it's better in terms of consistency also with SDI and to avoid these scenarios. But the main message actually is really, again, we had a lot of talk about this for classification of RA, but also for assessing the treatment target. The context is important. The context of your patient is important. If you have a patient with comorbidities, then your tool, your assessment tool, may not work properly. It's that simple. You have another disease that creates the problem. So we need to think about, we have these patients that have 28 tender joints and no swollen joint. And it's a diagnostic almost for fibromyalgia. Or we have, patients with infection who have high CRPs, but no swelling and no other symptoms of disease. We would not change a DMARD in these patients. It's logical to us that we would give this patient an antibiotic. But it should be logic for us in the first scenario with the depressive fibromyalgia patient to also not change DMARDs, but treat the pain syndrome, which is difficult, I agree, but this is the conclusion. Again, people would say, oh, the criteria don't work. If you have these depressive patients, the fibromyalgia patients, it doesn't work, the bad criteria. They are bad if you don't use them in the right patient. They are bad if patients have other diseases that you do not consider but blindly follow treat to target. Yes, then you're over-treating. If you change the biologic in a depressive patient who has a patient global that is high and no inflammation. But I think you can answer the question. Stringent remission is not always necessary. 3 scenarios. The long-standing disease. We said biologically treated patients, they may not progress, even if they're only in low disease activity. And the third one is comorbidities like fibromyalgia, pain syndromes, where you should not go for change in DMARDs. All these scenarios where you're not on target require you to do something. But there's other people who say the opposite. Is clinical remission enough? We were just wondering if we can accept higher levels. Now people say, well, clinical remission is not enough. We should go for subclinical remission. And the way to study this would be to really take a population and you randomize them to a treat to target with a clinical target. Could be the Boolean remission, could be DAS remission, SDI remission. And a second arm that has a clinical target and an imaging target that can detect, the imaging target can detect subclinical inflammation, ultrasound or MRI. Whenever you fail in both arms to reach the target, so all these arrows, you're escalating therapy. And the escalation of therapy is the same in both arms. And of course, you will escalate more frequently in arm 2 because, if there you also have to increase therapy if you're in clinical remission but have hypervascularization, power Doppler, bone marrow edema on imaging. But you're using the same treatments. And then you're asking the question, what's the outcomes? Are they different? What's the p-value? There's 3 studies that have done this, 2 in ultrasound and 1 in MRI for the imaging target. And all of these were negative for the primary outcome, saying that there is no clear added value of monitoring patients longitudinally for subclinical arthritis and treating this arthritis as opposed to following patients clinically for arthritis and treating clinical arthritis. To be fair, there have been differences in some of the secondary outcome measures. But personally, I was very relieved when I learned about the negative results because it would have killed my clinical practice if I had to do ultrasound on every patient at every visit to do proper state-of-the-art management of rheumatoid arthritis. This may not be necessary. So, clinical remission may be enough. Then, of course, we were talking about targets all the time, and management is about what we do. This is what the first part was the strategy, how do we do it? And the second part is, of course, what are we using, which drugs? And it's a very simple question. Treating RA is easy in the beginning. No? What is the green? It's relatively easy how we start treating most RA patients with methotrexate. So that's the good news. And there's people who say you could also start in some patients with a combination with biologics or more aggressive treatment with targeted therapies. If you have poor prognostic markers, then you can win time. And it's true, actually. It is an economic question, and it's a question of stratification of patients. What you see here is one of these models that stratify patients for the risk of rapid progression. And you can see, depending on rheumatoid factor positivity, the CRP value, the presence of erosions or absence of erosions, you can see, and the swollen joints, that you can put patients into boxes for the risk of structural progression. And of course, if you're on the top right, with almost 50% risk of rapid radiographic progression, you could argue, yes, I would rather consider in that patient on the top right to use a combination therapy a priori as opposed to methotrexate than in the left bottom with 5% of risk for rapid radiographic progression. It's a clear difference. Currently, in most healthcare settings, we have to start with the cheapest options that are effective, and this is methotrexate has still a very good balance on this. But this could help in a world where we could just make decisions without thinking about reimbursement. This could, guide treatment decisions. But we have a problem when methotrexate fails. Then we're really in trouble, because we have a lot of treatment options, no? And this is the categorization of the choices, and you can see there's, of course, the synthetics and the biologicals. There's a few other conventional synthetics next to methotrexate that we use or not use depending on which healthcare setting we're in, leflunomide, sulfasalazine, hydroxychloroquine, and there's targeted synthetics, so drugs developed, also small molecules developed to specifically interfere with some of the pathogenetic process, whereas the conventional synthetics we still somehow don't know how they work. They have been empirically used in rheumatoid arthritis and worked. And we have the biologics, again, targeted therapies. For most of these options of targeted therapies, includes targeted biologic and targeted synthetics, we had, or at least for targeted biologics, we had this precision gap. All of these drugs worked to a similar extent in all of the studies. So if you looked at studies of methotrexate naive or DMAT naive patients in the middle row, or methotrexate failed patients, rather, you have the 60-40-20 rule. 60% ACR 20, 40% would achieve a 50% response, and 20% a 70% response. And that was irrespective of which compound I used, whether it targeted a cytokine, or whether it killed some B cells, or whether it blocked co-stimulation, all different modes of actions, and they're all giving the same result in the study population. Precision gap. And if you look at the few head-to-head studies for different modes of action, like here, abatacept, clearly different to adalimumab, you see how striking this 60-40-20 rule is. Because you don't even need to know the population. You can look at the result and say what population it was. And of course, since it's 60-40-20, it must have been a methotrexate insufficient responder population. So, good, but which one of these treatments should we use? Biomarkers. We had the discussion about biomarkers, and biomarkers have been incredibly unhelpful in deciding which drug to choose. Even high acute phase and tocilizumab, or high seropositivity and rituximab, high levels of TNF and TNF inhibition. When you look at the studies, the difference between the response rates are marginal or not present. And if you look at the summary of systematic literature reviews, it's a few years old though, but still to date, there's no good markers that help making a preferential treatment decision, one over the other. So the solution, it may be that, as Joseph and I wrote a couple of years ago, we should just forget personalized medicine and start treating the patient. Yes, if you don't have markers that tell you which drug to choose, just use one after the other. Just make sure you're using treat to target. And just make sure you're using none of these therapeutic options longer than 3 months if it doesn't work. Could be a pragmatic approach. And in the absence of biomarkers, this is what we often do. We just pick one. Often enough we're regulated by the payers what we have to choose. But otherwise, we just have to do treat to target. If we do proper treat to target, we waste the least time of the patient's course, even if we picked the wrong drug. That's the theory behind it. But there's more than that. There's, of course, the whole, and I believe the most important part of making a treatment decision in rheumatoid arthritis is this here. It's the comorbidities of a patient. We never talk about this, but this is what we do in clinical practice. We think about the risk for tuberculosis and choose other drugs, or we don't use one drug in heart failure patients, and we don't use another drug in patients who have diverticulitis, and we don't use another drug if this patient has recurrent zoster. We do this in clinical practice. It's just not formalized because safety data are always cloudy. But there is a few clear safety signals that differentiate the different compounds, and there might be patient profiles with their comorbidities. When you map them to the risk of the different drugs, you could reasonably say, if they're all working the same on efficacy side, well then let's pick the possibly safest drug for the patient at hand. The EULAR management recommendations have been updated, and they don't go into all this detail. Like most of the management recommendations, they're the smallest common denominator of the evidence. But they're good guidance, and I think I'm not going into much detail because I've spoken a lot already today. You know the algorithm. There's only a few new things in the algorithm that I just want to highlight. One is that clearly it has even more strongly been emphasized that we should use glucocorticoids as bridging therapy, but clearly more emphasized that this should be done really short term, meaning stop it, taper it to zero as quickly as possible. And there's good rationale behind it. This is the data supporting that cumulative glucocorticoids are clearly associated with cardiovascular risk, and other studies that I'm not going into this. Other studies that show that if you use, without explaining too much about the details of this study, but if you compare a strategy with conventional DMARD use plus glucocorticoids, the blue bar, and you compare it with 3 combination strategies of methotrexate with different biologics, you get more or less similar results. So glucocorticoids in the first step of the algorithm can be acting as potently as a potential combination therapy with a biologic, and that is relevant to know. So the second step, the important thing to consider, and I'm aware you will hear a lot about JAK inhibitors today already, and this is just the modification based on the studies that came out, or the study that came out last year about the risk for cardiovascular disease and malignancy afflicted with tofacitinib, and potentially we don't know other JAK inhibitors, it's unclear. But the drug class has been affected by that study, although most observational studies show no increased risk for either. This was a randomized controlled trial, which by definition is the highest level of evidence. So what we need now would be a second randomized controlled trial that doesn't show it to disapprove. Unfortunately, even 10 or 20 or 30 observations in populations, in epidemiological studies, always will have difficulties to disapprove this finding of the risk, because this was a randomized controlled trial. It's a dilemma. But still, this drug class was the first drug class that broke the 60-20, 40-20 rule. JAK inhibitors had about 10% more response in some of the pivotal studies. So they're very useful for treating our disease. So what do we do now? And the decision of EULAR was really to say that the class is important, but we need to consider the risk. We don't put it exactly on the same level with biologic DMARDs after methotrexate failure, but we do risk assessment. And you can see the risk assessment is in the footnote, where hopefully people will still read it. But it's very generic. It says people with risk factors for cardiovascular disease and risk factors for malignancy. And if you put it through, everyone will have some risk factors. So it will come back to looking at not giving it to people who have multiple or severe risk factors for cardiovascular disease, or a history of a malignancy, or family history, or things like that. But it's not specified. It's again clinical decision that can only be embedded in recommendations, but we have to do the ultimate decision on a case-by-case basis. So with this, I'm at the end of my second presentation, and I think I was doing better than in the first one time-wise. Thank you very much for your attention.
Thank you, Daniel. ¿Preguntas, auditorio? Número. Alonso. Enrique. Doctor Soriano, una pregunta. Tenemos 5 minutos para preguntas. Ok. 5 minutes.
Okay, good.
Por favor, conciso.
Yes. Thank you, Daniel. That was a great talk. I want to argue a little bit related to the ultrasound in clinical practice, because I think that one of the problems with those studies are that I don't think those are the correct design to answer the question we want, because in most of the patients there will be a good agreement between the clinical assessment and the ultrasound. But the question is, what happened in those patients in whom there is no agreement? So we think that there is no swelling, and that is a small proportion, and I think in those patients we have to focus what will be the outcome if we follow one or the other option. So that's a comment. I want to hear your opinion on that. But the other thing is, apart from that, I think that there may be some place not to use it in every patient, but for example, if we are planning to taper the drug, for example, the biologics, I think that it might be useful to see that the patient is not only in clinical remission, but also on imaging remission. So that's my opinion.
It's exactly. I think you need to find the spot in clinical practice for ultrasound that allows you to reasonably do it in those patients where you can get most of the information and maybe don't have to do it. I said I was relieved from the data. I was relieved because if this were positive studies, then I would not be treating state of the art if I didn't do an ultrasound at every visit on every patient. That's why I'm relieved. I'm absolutely in agreement with scenarios for differential diagnosis, for tapering questions, for special clinical situations is exactly what you outline. But there's also good evidence from studies that we did that sustaining clinical remission leads to a resolution of subclinical remission. So you could, if you don't have the time to do the ultrasound on every patient, if you just sustain clinical remission, which is a high enough bar we know in clinical practice, we know that subclinical remission over time decreases without being measured. We did that study, and it was a pragmatic way to say, okay, we can save time. Just focus on the clinical remission and maintain clinical remission, and you don't have to do the imaging, and keep the imaging and proper imaging for those situations where clinical decisions pend.
Okay. ¿Alguna pregunta adicional? Yeah. Por favor. Usted, Pedro, y usted después.
You know, Daniel, sometimes you cannot choose in using biologicals because, for example, you have a patient with this history of using 3 anti-TNF, tocilizumab, rituximab. What do you think about switching between JAK inhibitors?
I think it's we had these questions about TNF inhibitors. You know, when we started with the TNF inhibitors in the early 2000s, people were asking the same question. It was very difficult to answer, and there were always data supporting it. But I think it's a clinical in a clinical setting. If it depends on how well someone responds to one mode of action. So if for example, you can do this for JAK inhibitors or TNF inhibitors. If you have a patient that does not respond at all, you may be inclined to switch the mode of action. If you have someone who responds but something happens, mostly is that they stop taking the drug, or sometimes with biologics, maybe anti-drug antibodies and things like that. But you may think about changing to another member of that class. But in principle, I'm personally in favor of, if we have different modes of action and we're unsatisfied in a single patient with one of them, why not trying others before maybe coming back? I think the cycling within one can be done, but if I have other options that may give maybe an added value to that specific patient, why not trying this and come back if that also doesn't work? So that's a... Yeah.
Are you usually using a subcutaneous methotrexate?
We are using too little of it. And we're actually now in a large EU project, we're planning a study to optimize methotrexate. So take all patients who don't have the optimal dose and the oral route and say we go to 25 milligrams sub-Q and see how many patients we can really push from maybe low disease activity to remission only by doing this. We know bioavailability gets better in the higher doses, and we know tolerability gets better with higher doses. So I agree with you, this is in my country and in many parts of Europe underutilized.
Okay. La pregunta al fondo.
Over here. Thank you for your great talk. I would like to know your opinion. Here in Colombia, we have a high incidence of tuberculosis. I would like to know your opinion about the combination of methotrexate with leflunomide.
With leflunomide? Yes. We do it rarely in Europe. It may be a good option if there's reasons for not going to biologics for TNF inhibitors. It may be a good option. And I hear people telling me, I'm aware that I think I went to Brazil, I know there they use it a lot. I'm not sure in Colombia use it a lot too. I think people tell me it's safe. Safety was always my greatest concern from the studies that I saw. But apparently in clinical practice, this is not what people see who use it more frequently. So you are more the experts than me for the combination. I think safety monitoring is key for these patients, but it's a good option to move on in a patient maybe with not a lot of risk factors for progressive disease. So if you're failing methotrexate and you have the high seropositive, high remaining disease activity, already erosive patient, maybe it's not the option that you choose in this kind of patient, where you know that biologics have a strong effect on structural progression and on inflammation. But in other patients?
Thank you.
Ok, muchas gracias. Démosle las gracias al doctor Aletaha con un excelente aplauso por esta gran conferencia que nos ha dado y sus deseos de responder todas las preguntas. Thank you, Daniel. Excellent.